Our next speaker is someone I've known for a long time. When I first came out to Lewiston, Idaho in 1984 to practice medical oncology, I quickly learned that I could call John Thompson at the University of Washington for advice, and he always gave me good advice, so we've had a long relationship that way. So it's really great to see you again, John. I want to welcome you to the podium to give us some updates on management of melanoma.
Thank you for that very nice introduction and the opportunity to come back to this lovely location. Yes. I was able to give a talk here about 10 years ago on melanoma, and not a single drug that I talked about at that time I'm going to talk about today. The completely wipe the slate clean, and we have better drugs, more opportunity for helping our patients. Thank you. Okay. Oh, let me just use that, or it might be.
No, you got. Do you have questions in your slide?
No, no questions. No, I don't need that. Thank you. Thank you, Dr. Shaw. Okay, so some have said that, some pundits have said the last 3 or 4 years at ASCO were the year of melanoma. We enjoy that in the melanoma clinic because there's been a lot of progress. And I'm going to talk about the drugs that you see listed here. Will this show bigger on the screen, or is this it? Or is that? That's how it is? Okay. Okay. We're going to talk about, when I see a new patient in clinic who has advanced melanoma, I generally tell them that there are 2 broad pathways for treatment. One is an immunotherapeutic pathway, and the other is for patients who have a mutation in BRAF, and we'll get to that later in the talk, in which BRAF-targeted agents may be an option, and I'll touch on all of these agents. Now, the take-home message here is that for immunotherapy, this does apply to all the patients that we see, potentially, except those who have an autoimmune condition such as rheumatoid arthritis or ulcerative colitis. They would not be good candidates. We have to remember that the onset of activity is variable. It may take quite a long time. However, the payoff, if we're lucky, is that there may be long-term responses to immunotherapy. By contrast, in those patients who have BRAF mutant disease and in whom we choose one of these BRAF-targeted agents, there's a very high response rate, and sometimes responses are evident within a week. Unfortunately, there's often development of resistance, and we'll talk about that later in the talk. Okay, so the first immune checkpoint drug, and I think many of you know about this already, Ipilimumab, has been on the market for about 4 years now. This is an artist's conception of the responding T cell receiving a signal from an antigen-presenting cell and turning itself on, producing IL-2, increasing the number of T cells. But rapidly, there is a counter-regulatory effect with CTLA-4 coming to the cell surface that dampens down this immune response. And the Ipilimumab is a monoclonal that blocks CTLA-4 and thereby prevents this negative effect. So it's like, if you will, removing the brake pedal. Rather than hitting the accelerator in the immune system, we're removing an inhibitory signal. And this results in an amplification in T cell function. Now, I'm not going to go into all the trials with Ipilimumab because I think many of you are already familiar with that. But we now have data with Ipilimumab in patients with metastatic melanoma that shows a plateau on the response curve that goes out to 10 years. Now, when you see a curve like that, that implies that these patients have a very low probability of progressing with their disease beyond, say, about this point. This is the blue line are those who were not treatment naive. The yellow line is for patients who were treated without prior systemic therapy. So this sets sort of the principle for immune checkpoint therapy. The other point I made is that the onset of responses may be delayed, and I have a couple of examples of that. Here's a patient with melanoma, treated with 4 doses of ipilimumab, and by week 12, the CT scan is not looking very promising, increasing disease in the liver. However, without additional therapy and further follow-up, the hepatic metastases started to regress and completely regressed. So this is an example of a delayed response to immunotherapy. Another example, looking over this slide, is a patient with more visible disease on the chest wall. Again, ipilimumab for 4 doses and apparent progression of disease. And then without additional therapy, gradual regression of disease and complete elimination of the metastatic melanoma. Another clear example. So if we're using this type of drug, we have to be patient sometimes and think about our assessment of whether they are responding or failing treatment. Ipilimumab, however, comes with a number of toxicities that are all related to overstimulation of the immune system. And the most common immune-related adverse events are shown in this slide and include pruritic skin rash, which happens in about 40% of patients, GI side effects including diarrhea and colitis, which can happen in about 25% of patients, and then less common toxicities including hepatitis, endocrinopathy, or neurological problems. We'll spend a little bit more time talking about this later in the talk, but I think it's anyone wanting to use ipilimumab in the clinic should educate themselves on the way these side effects present. There's an excellent series on the web that BMS puts up on yervoy.com that talks about all of these side effects and gives very good algorithms for managing these side effects. The other important thing for those who work in the clinic is that I think it's critical for patients to be educated about the side effects. There are information that can, like a patient wallet card that can be sent home with them, other handouts that will help them understand the toxicity. I always tell the patient, once we start treatment, if you start getting frequent bowel movements, it's not the takeout Chinese food you had last night. It is the treatment that you're on, and please call us immediately. Okay. Now, the other more recent immune checkpoint drug that we'll talk about are the antibodies, or multiple ones, that block PD-1. PD-1 is another negative regulator of T-cell function that, in a manner somewhat analogous to the CTLA-4 story, is upregulated in the tumor microenvironment and causes a state of T-cell anergy, or T-cell exhaustion. So T-cells may be present within a tumor, but because of binding of PD to PD-L1, the T-cells are rendered ineffective. And there's a little bit of speculation about where anatomically these two processes are most manifest. I think some are saying that the CTLA-4 immune checkpoint system is more in lymph nodes, and this is more actually in the tumor itself, but I think there's probably a lot of overlap in that. Now, one of the first studies that was presented, 3 years ago at ASCO was a trial in patients with metastatic melanoma using infusions of an antibody to PD-1. And you see here on this spider plot, each line is a patient's tumor measurements, and there was a clear trend toward reduction in tumor size, and some of these were very prolonged. And there was also at least one case of an enlargement followed by a shrinkage, as I showed you in that some of those earlier slides. We're seeing a lot of this in clinic, patients who have a significant reduction in their tumor size and then a plateau at maybe a 30 to 50% reduction. That may be the most common outcome with PD-1 therapy. What are some of the clinical trials with PD-1 antibodies? This is a paper that came out in Lancet Oncology last fall, in which the investigators were looking at the role of pembrolizumab, one of the anti-PD-1 monoclonal antibodies, in patients whose melanoma had progressed or had failed to respond to ipilimumab. And so they had, in this study, 173 patients that were treated at either 2 or 10 milligrams per kilogram of this antibody. They found that the safety profiles were similar. Response rate in this group was 26%. And so for the package insert now for pembrolizumab, it's 2 milligrams per kilogram every 3 weeks. And this and other data led to the FDA approval of this agent in metastatic melanoma. Now, it's the FDA label is for patients who progressed after frontline Ipilimumab. As you'll see in some of the upcoming upcoming talks, that's not necessarily the case anymore, and both pembrolizumab and nivolumab are now being moved up into first-line therapy. So this is more detail from that paper showing a waterfall plot of the tumor size in these patients and the swimmer plot showing the duration of response. In the interest of time, I'm going to skip ahead a little bit. This is the toxicity. Is the toxicity like Ipilimumab? Well, a little bit, but it's in general milder. The most common toxicity is fatigue, which usually is not disabling, but occasionally we have to hold a dose or give a longer interval between doses to allow patients to accommodate fatigue. Other immune-related adverse events such as colitis or hypophysitis can happen, but at a lower rate than with Ipilimumab. Some other side effects have appeared with the PD-1 agents, including occasionally nephritis or pneumonitis. So pay attention if your patients develop a dry cough and rales and hypoxemia, that may be a sign of pneumonitis, or if they start developing a rising creatinine, that may be a sign of nephritis. Similarly, this follow-up paper, this is a later paper than the one I just showed you. This was published this year in New England Journal of Medicine and was a study of patients, previously untreated metastatic melanoma patients. The only exception is that none of the patients had BRAF mutation. And 418 patients were enrolled in this trial and were randomized to nivolumab, another monoclonal antibody to PD-1, at this dose and schedule versus dacarbazine. And of course, you remember dacarbazine was the old workhorse many moons ago. We're not using that much anymore. The response rate with nivolumab is shown here versus the response rate with dacarbazine, and I think you can see both the percentage of patients and the depth of tumor shrinkage is much more noticeable with nivolumab, as is the progression-free survival curve. This clearly favors nivolumab compared to the old standard of dacarbazine. Now, the paper that got everybody excited this year at ASCO was a larger prospective randomized phase 3 trial, summarized in this slide. This was in about 1,000 patients with metastatic melanoma, previously untreated, who were stratified by various factors shown here. They were randomized in a 1-to-1-to-1 ratio to either nivolumab plus Ipi, nivolumab alone, or Ipi. And treatment continued until progression or intolerance to this treatment. This has been published now in the New England Journal. And this slide shows the progression-free survival in these three curves. This is the combination in orange. In blue is the nivolumab monotherapy, and Ipilimumab, the monotherapy here. And I think you can see based on these curves, there's definitely superiority of the two nivo-containing arms compared to Ipi, which is the reason that the NCCN Melanoma Committee now has moved PD-1 agents to frontline, and we've actually demoted Ipilimumab from frontline to second line. There's a question about what's happening out here in the right-hand part of the curve, and there are not enough patients here to really comment on that, but at least if you look at this part of the curve, there's a better progression-free survival with the combo compared to nivo monotherapy. And response rates are shown in this slide. The overall response rate, if you include both complete and partial responses is in the high 50% range with the combo, around 40% with Nivo monotherapy, and around 18% with Ipi. And again, these are the waterfall plots showing each vertical line is a patient, and the amount of tumor shrinkage is shown as the bar is going below the x-axis or above. And with Nivo plus Ipi, you can see that the vast majority of patients had some degree of tumor shrinkage. With Nivo alone, the results here, and with Ipi, results are shown. So the conclusion of the presenters at this year's ASCO was that both Nivo alone and the combination significantly improved progression-free survival and response rate versus Ipi alone. And the combination also had a numerically longer progression-free survival and response rate versus Nivo alone. Now, what we don't have are overall survival results yet. That's not, the data are not mature enough yet for that. They looked at intratumoral PD-L1 expression, and this is something I'll talk about in the next few slides, as a biomarker to predict response to this type of therapy. And it looks like if tumors have greater than 5% PD-L1 expression, both Nivo alone and Nivo plus Ipi result in similar clinical results. So this is raising a lot of discussion about whether a biomarker will be built into our treatment algorithm for using immune checkpoint drugs. And I'll talk a little bit more about this. What are the data with the biomarkers? It's sort of variable. It depends on who's reporting the result and which assay is being used, the antibodies being used, the techniques. The first presentation in this was by Suzanne Topalian, and this was, she published this in New England Journal, looking at melanoma and response to anti-PD-1. And if the tumor staining for PD-L1 was positive, there was a response rate of 13 out of 31. If staining was negative, there were no responders. This looks like a pretty good biomarker. But subsequent papers have not confirmed that, in that there's still a trend toward better response in the PD-L1 positive patients, but there are enough responders in the PD-L1 negative group that no one's willing to say, oh, if you're PD-L1 negative, we're not going to treat you with a PD-1 agent. So where are we going from this? I've got a few slides here. I think in the interest of time, I'm going to delete some of them, but I'm just going to illustrate for you how much work is going on in this area of developing a biomarker to predict response to these immune checkpoint drugs. It's interesting, if you look at inside the tumor, if there's T-cell infiltration, this correlates with the ability to respond to immune checkpoint drugs. If there's PD-L1 expression, this likewise correlates. And what we're forming is a theory that T-cells move into tumor, perhaps in response to some antigen that's being expressed on the tumor cell. Also, perhaps because the tumor is not able to release negative cytokines to shut down the immune response. And this causes release of cytokines such as gamma interferon by the T cells. And we know that gamma interferon upregulates PD-L1 expression, and this may, in fact, lead to a cycle that's increasing T cell infiltration into tumors. So if you see an inflamed, what's called an inflamed phenotype, that is a tumor with infiltrating T cells and PD-L1 expression, this is the type of patient who is more likely to respond to the immune checkpoint inhibitor drug anti-PD-1. Now I'm going to skip over some of this in the interest of time, just because I want to get to the next part. So biomarkers, and this is from Mike Atkins, who's Dr. Melanoma for the United States, I would say. He gave a fantastic response to the previous phase 3 trial at ASCO. So if you want to look at it online on ASCO, I commend that to you. Absent better biomarkers, decisions on therapy will likely be based on clinical grounds. So in his opinion, and I share this, the combination of Nivo and Ipi should be preferred treatment for those who need a response rapidly and who can tolerate it. By this, I mean people who are young who have access to the clinic, who are good communicators, who understand the potential for serious immune adverse events and are willing to work with the clinical staff and who don't have any comorbidities. What about people who don't meet those criteria? What about older people who maybe have comorbidities, who wouldn't do so well if they develop severe colitis or hypophysitis, who might have diabetes and not do so well if you had to put them on high-dose steroids? In those patients, Nivo or Pembro, one of the anti-PD-1 antibodies, is acceptable treatment, irregardless of the PD-L1 status, where toxicity is a concern. So this is where the judgment comes in the clinic in terms of how you treat these patients. Now, moving on, I do have to put in a plug for work that's going on at the Hutch and University of Washington with adoptive T-cell therapy. This is something that you've heard about that's been pioneered by Steve Rosenberg at the NCI, where we're trying to identify the T-cells that are responding to melanoma-specific antigens, amplify these cells in number in vitro, grow them into an army of T cells, and then be able to give them back to the patient, followed by other T cell stimulatory factors. And this type of work is going on. My colleague Sylvia Lee is working on this, and these are data from Steve Rosenberg's group at the NCI. Overall survival of patients treated with TIL therapy, and most of these patients had been pre-treated with all sorts of other systemic agents, but there still appears to be a plateau in survival at about 30%. Interestingly, patients who had prior immune checkpoint inhibitor therapy did just as well, if not better, than the other patients. So this would be applicable for patients who have progressed despite immune checkpoint therapy. I'd also like to put in a brief plug for our Phase 1 center. We have a number of drugs that are in development now that are going to be added on to the backbone of Ipilimumab and PD-1 agents. There's some additional immune checkpoint inhibitors that are shown here. LAG-3 is in clinical trial in Seattle now. And other agonist antibodies. These are the ones that actually act more like hitting the accelerator. These are antibodies that bind receptors that directly stimulate T-cell activity. And there are now trials with PD-1 plus OX40 ligand, with OX40 and CD137, 41BB. So there are some other options in case patients do not respond to the available agents. Now, in the remaining time, I'm going to shift gear and talk about the targeted therapy part of melanoma. I mentioned that at the beginning. This is a hypothetical melanoma cell with a receptor tyrosine kinase that's signaling down the MAP kinase pathway. And here is a mutation in one of the molecules here, BRAF, that switches on and sends a constitutive on signal driving melanoma cell growth. We know that BRAF mutations occur overall. About 45% of our patients have them. It's interesting, if you look at age breakdown, this is the frequency of patients with melanoma, sort of a histogram of melanoma. In the younger age bracket, virtually all patients, 100% of patients, have BRAF mutations. As you get out into the 80 to 89-year-old set, you see that it's a much smaller percent who have BRAF mutations. You're probably aware of the pivotal study by the folks at Sloan Kettering, a big cooperative group trial with vimurafenib, the first BRAF inhibitor, versus dacarbazine. And the thing here is to illustrate the rapid onset of response. Here's some PET scans of patients with widely metastatic melanoma where the FDG activity goes to almost zero within 2 weeks. Amazingly fast responses. And they also saw better progression-free survival and overall survival compared to what was then a standard, dacarbazine. The problem is that patients acquire resistance to this medication. And so Later work has developed inhibitors of the downstream molecule MEK, and currently the favored regimen, if you're trying to do targeted therapy, is to inhibit both mutant BRAF and MEK with dabrafenib and trametinib. What are the results? This is also from ASCO this year. It's a longer-term follow-up of a prospective randomized trial with almost 1,000 patients, in which patients with BRAF mutated melanoma were randomized to receive dabrafenib versus dabrafenib plus trametinib. And the response rates were higher with the combination. You can see the response rates are 69% response rate with the combo versus 53%. Not a dramatic difference, but a statistically significant improvement in response rate. When you combine these two drugs, you do see emergence of a very classic toxicity, that is fever, and we'll talk a little bit more about that. But this shows the progression-free survival, and that's looking a little better than we had initially thought. We're starting to see some patients who are remaining free from progression out beyond a year now with this combination. And this shows the overall survival curves for these two groups. This is the dab-tram, so to speak, group, and then the dabrafenib-only group. This slide is way too hard to read, but basically it's just to summarize this entity of fever, which we're seeing quite frequently in patients who are on dabrafenib trametinib. Usually comes on 2 to 4 weeks into therapy. Sometimes becomes quite severe, and people can get dehydrated and need to even have IV fluids to resuscitate themselves. Typically, we'll stop the combination, let the side effect go away, and then we can reintroduce the drugs, and sometimes patients will tolerate reintroduction. Other times, we have to put patients on low-dose prednisone in order to be able to continue the dabrafenib trametinib. So I'm getting near the end here of my talk. So a couple years ago, we were looking at trying to figure out how we should start therapy with a metastatic melanoma patient. Immunotherapy didn't have a very rapid onset of activity, but it had the possibility of a durable response, whereas targeted therapy seems to have a very rapid onset of anti-tumor effect, but maybe not a durable effect. I think now the picture is getting less clear, because we're seeing that with combination of dabrafenib and trametinib, there may be some durability. But with immunotherapy, now with the combination of ipilimumab and nivolumab, we're seeing response rates that are pushing 60%. So how do we advise patients? For patients in our clinic who are wild type and they're asymptomatic, good performance status, we'll typically start either with an anti-PD-1 or a combination of Ipi plus Nivo. If they're BRAF wild type but have very bulky symptomatic disease, we can still use these agents now, knowing that the response rates are higher and time of onset of response is quicker. Or in certain really desperate cases, we may have to start with chemotherapy or biochemotherapy to try to debulk the disease and then move to immunotherapy. In the patients who have BRAF mutated disease, we'll still often tend to start with immunotherapy and save the dabrafenib trametinib for if they don't respond to immunotherapy. And so in conclusion, a lot's happening. A lot has happened in the last few years. We're now looking forward to the future with new immune checkpoint inhibitors that are coming down the research pipeline, or agonist antibodies, and these are going to be combined with the backbone of anti-PD-1 and ipilimumab. A lot of work's going into T-cell therapy. We're still doing some work on lymphokines such as IL-15 and IL-21, which may combine with the immune checkpoint drugs. And receptor-directed cytokines is another area of research. In targeted therapy, there's a lot of work going on in trying to dissect out the mechanisms of resistance and come up with better regimens such as pulse therapy or intermittent pulse therapy to get around the problems with resistance. So that concludes my remarks, and I maybe will wait for the panel discussion for questions. Thank you for your attention.